Hello, I'm David Lim, and welcome to another CPD podcast from Health Ed. In today's episode of the Clinical Takeaway, I will be speaking to Alison Slater on fascia and why it's important.
Thank you, David. First and foremost, I'm extremely grateful for the opportunity to speak to you today, primarily because this is a subject very close to my heart. I've been a physiotherapist for the last 40 years, and I did my undergraduate degree with a major in anatomy. And lo and behold, in 2007, I was at a World Congress on low back and pelvic pain, and I met a gentleman by the name of, he's now Professor Robert Schleip. He's a German molecular biologist, and he basically started talking about fascia in the middle of a low back and pelvic pain congress. And I must admit, I was fascinated, and there's no pun intended in that, but I was absolutely enthralled by what he was saying. And having done my undergraduate in anatomy, I thought, why haven't I heard of this before? This is incredible.
This is the Clinical Takeaway podcast from Health Ed, where we interview leading medical experts on important topics that can positively change the way you practice. Here's your host, GP and medical educator, Dr. David Lim.
Alison, I have to admit, when I was given the topic of this podcast, which is fascia, I struggled to understand why would I be talking about fascia. And to allow this context to sink into my fellow GPs' minds and understanding, I'm going to just ask you a really simple question. What is fascia? And why is it important that we understand it?
That's a great question. So fascia encompasses a number of things. To put it in terms that we all know, ligament, tendon is fascia. Tissue immediately underneath our skin is fascia. That's what creates glide. So even if we just put our fingers on, and this is something that we'll talk about a lot more as we go on, but even if you put your fingers on your forearm and you move the tissue back and forth, it is fascia that is allowing you to do that. If that glide doesn't happen, we know that we've got pathology. Then when we get down into the deeper layer surrounding the muscles, and this is a point that I cannot stress more enough, muscle tissue, and I want you to think about it like a chicken breast wrapped in cling film. Mm-hmm. The cling film is what we call the epimysium. It goes around the entire muscle. The epimysium is very, very much in contact with the tendon at either end of the muscle. Within the muscle itself, so within that chicken breast, we all know that we have fascicles, bundles of muscle fibers. Each fascicle is surrounded by fascia, and every muscle fiber within that fascicle is surrounded by its own fascial sleeve. So we have the epimysium all the way through to the endomysium, and every single part of that is innervated. So where we used to think of, say, Golgi tendon organs as only being in the tendon, it's actually in the epimysium. Okay, so there is massive conversation going on between our fascia and the brain. So there's constant feedback. Before I go on with that, let's sink a little bit more deeply. Then we get down to visceral fascia. So all of the linings of the body are created by fascia. Every organ is covered in fascia. And the essence of fascia is it creates a capacity to glide. So we all know that our organs need to be able to glide relative to each other. We all know that to perform the most basic of movements, each of our muscle bellies has got to be able to glide independently of the structures around it to perform all the clever things that human beings can do. We understand pathology, and this is something that GPs really want to be aware of when we don't have movement available. And that can happen for a number of reasons. As I said before, tendon is considered fascial tissue. Ligament is considered fascial tissue. And when we think about traditional anatomy, you and I both learned that every muscle has its origin on one piece of bone and its insertion on another. It might shock you and your audience to know that take gluteus maximus, for example, 75, if not 85% of the fibers, the distal fibers of gluteus maximus, have no bony insertion at all. So I dare say you've heard of the iliotibial band. Every runner who's ever come in to see you is obsessed with their ITB. That is the conduit by which the glute max talks to the knee and then the ankle and the foot beyond that. So instead of thinking about, and we have a terrible habit of doing it in medicine and healthcare, is siloing our profession, but we cannot afford to silo the body because every part of the body is talking to every other part of the body. So when we think about pain, is that the source of the pain, or is that the tissue that's taking up the load? And as a result, is that a manifestation of a problem somewhere else in the body?
Oh my goodness gracious, Alison, can I just pause for half a minute to catch my breath?
Let that sink in.
Wow. Okay. So you're really saying that every single structure in our bodies, down to the individual muscle cell, they're all encased by something called fascia.
Correct.
And that fascia is enormously important for many reasons, two of which is to provide glide and therefore smooth movement, and to somehow provide communication between each part of the body and the brain.
Absolutely.
Okay, so we're beginning to think of two things. One is a static structure that's kind of like a lubricant somehow, and the other structure which is like I'm talking to you, so it's like a coaxial cable, if you like.
100%.
Okay, now for fascia to provide glide, I immediately think that in itself, the fascia is not a one-piece structure, that somehow the fascia in itself must be able to both absorb the glide or be lubricated. So is it multiple layers with lubricant?
Great question, David. So when we think about the muscular fascia, that we spoke about in a little bit of detail before, and I want to get back to that because it's terribly important. But when we look at that tissue, we have a slightly thicker fascia called an aponeurosis that is literally a division between the superficial fascia and the muscles. So then we've got the epimysium underneath that. But think about that aponeurosis. It's a multi-layered structure and thicker bands. It's quite stiff. Not stiff, that's the wrong word. It's hardy. It's very stretch resistant. Mm-hmm. But there's loose connective tissue in between those layers. So it looks a little bit like a cake. So there's multiple layers. That loose connective tissue has movement capability. So each of those tissues can glide relative to another. When we get down to the muscle tissue, and there's that magical stuff, one of the sexiest sort of topics going around is hyaluronic acid. Mm-hmm. Now, hyaluronan is the proper name for it, but we'll call it HA just for brevity's sake. So HA is very, very abundant in that, and it's a glycosaminoglycan, so it has the capacity to absorb massive amounts of fluid. So it's the perfect thing to be a lubricant. That is very abundant in that loose connective tissue, but it is also that little fasciocytes that secrete it are lined up along the borders of the muscles, and it is secreted to create that glide in between the tissues. So do we want to talk about pathology, or shall we leave that a little bit later?
We'll leave that till later, because I'm just trying to understand how all these leads to soft tissue issues. For example, I'm just going to quickly hit you with this. Damage to muscles causing inflammation, and therefore for all doctors, once the acute inflammation settles, great. But if it proceeds to chronic inflammation, you have calcification and fibrosis, and we know that fibrosis causes shortening, and oh goodness, we have that causing shortening of muscles. We also know, at least I think I know, that people who don't use their muscles to the full extent, flexion and extension, and lie in bed, or do they have shortened muscles, and then we call it, or this sort of and the issues that come with it. Are you trying to tell us that this sorts of very simple, oh, it's your muscle shortening, it's the scar tissue, which is what I use as a paradigm to understand issues, is probably too simplistic?
Perhaps so. Now, the interesting thing is that fascia it's not just connective tissue. It's cellular, it's vascular, it's innervated.
Wow.
It's both a sensor and a responder. And this is where it becomes quite complicated, but quite simple. So there are fibroblasts within muscle tissue and within the fascia, I should say. And I want you to understand that we get 10 times more feedback from fascia to the brain than we do from muscle.
No way.
I have a little saying that muscle is the brawn, but fascia is the brains.
No way.
Controlling. So when someone leans forward in my clinic and they go, oh, I can't go any further than that, my hamstrings are too tight, I know that's fascia talking to me. It's not the muscle. So let's get back to inflammation. When there's like cellular activation in the theatre of inflammation, the fibroblasts which produce collagen. So we've got collagen, we've got cells, and we've got the extracellular matrix. And that is literally what fascia is, even though that'll appear in different arrangements depending on the job that fascia does in a particular area. So fibroblasts respond to cytokines. So your interleukin 1 beta, your TNF alpha, your TGF-B1, and collagen synthesis starts increasing. Now, interestingly, collagen can, fibroblasts, I should say, can morph into what we call myofibroblasts. So now they have a contractile capability. So when we think about muscle tightening up, is it that the myofibroblasts, which are super handy for closing wounds, for example, so they will pull in the edges of a wound. That's where the contractile element comes from. But they will contract the extracellular matrix. Now, we all know about mast cells as well. So in that scenario, the mast cells degranulate. Of course, they release histamine, proteases, and the inflammatory mediators. And that will sensitize nearby nociceptors. So this is especially important, and I am doing another chat with one of your colleagues about hypermobility, but this is particularly important if you've got someone who's got mast cell activation syndrome, because that's when you have these big inflammatory storms for no particular reason. So let's get back to inflammation. So when we are in a state of inflammation, the HA, the viscosity starts to go up. So those fascial layers become cohesed. The collagen starts to cross-link, and this is a term that you won't have heard before. It's called densification. So you've got densification, which is that stiffening, as opposed to fibrosis. Densification is reversible, fibrosis isn't, okay? So we're obviously going to get reduced flexibility in tissue. And the fibrosis can develop if we don't intervene quickly enough. That can be the problem. So once, as we all know, once those nociceptive fibers are annoyed, they become hypersensitive. And of course, that's going to lead to greater ectopic firing within those that are caught up in tight fascial tissue. So this is a huge area of investigation, that if nerve cannot glide relative to the fascia around it, of course, nerve is surrounded by its own fascia as are blood vessels, but if it can't glide, then you've got sticking and potential activation, overactivation of that nerve. And you can start to appreciate how a chronic pain pattern can build up. So this is when, you talk about doctors always being, oh no, fibromyalgia. I think that's the only thing that we can come to. You can appreciate that is a led to by a cascade of various things. And menopause is one of them, but we can talk about that a little bit later. Now, of course, because our nerve tissue and because our vascular structures are going through these connective tissue conduits between muscle, you can appreciate that if we're starting to get that densification in that tissue, it's going to affect our microcirculation, our capacity to move fluid out in and out of that area. And of course, that's just going to perpetuate the local inflammation and the swelling. So there's enormous implications for chronic pain if we don't intervene in a timely manner.
Alison, first of all, I think if it just completely changed my whole understanding of inflammation of soft tissues. It's absolutely nuts that it affects so many levels. I had never imagined, say, the mast cell degranulation could and would sensitize nociceptive receptors. Makes sense. Never thought about it. It also
Got a lot of things to think about, David.
And for the first time in my life, I'm really thinking about why patients do present with weird neuralgic or neuropathic type pain when I can't seem to find a really good reason why that they should have it. And this brings to mind questions like, how much pain, nerve type pain, do patients present with? Not just muscular pain and muscle stiffness. Do these patients with fascial dysfunction present commonly with neuralgic or neuropathic pain?
100%. And that's a huge part of my job, is making that differentiation. Is this nerve-generated pain, or is it more likely to be something that has been created by that densification? And so that sticking, that almost like, we talk about double crush syndromes and things like that, where we don't have enough capacity. So the nerve is being tethered at a certain point, and that can sensitize it more distally as time goes on. So you can appreciate that we can have that pain persisting well beyond damage resolution. Okay, so once the inflammation's gone, we can still have that pain. And this is where we all start to feel a little bit hopeless, because you think, what am I going to do about this? Because that issue has resolved, but this patient still has very severe discomfort.
Okay.
So, yeah.
So we come to this chronic pain issue later, because it's just incredibly important. Let me just go back one, because there's just so much in my head. I can't even get over this. One of the things that you mentioned that has opened my eyes is the fact that fascia and different structures with fascia communicate with each other over a long distance through your body. It's almost like the whole body talks to itself. And for the first time in my life, I'm beginning to understand a possible reason why we have referred pain. Is that one of the reasons why?
100%. That is 100%. And this, as I said before, differentiating between, okay, you have got a disc bulge and it's sitting on your L5 nerve root. Then we've got that beautiful clear-cut dermatome of symptoms all the way down to your foot. We know that's not always the case. So it's a matter of looking a little bit more deeply. And I think, from a GP's perspective, it's exactly the same as it is for a physiotherapist. Mm-hmm. How is that patient moving? If they're having to, say, step out of their shorts or something while they're in your practice, what's their balance like? Because one of the other really big jobs, given the amount of neural, the density of nerve feedback coming from fascia is a big proprioceptive system as well. So what's their balance like? How are they moving? Do they move easily or don't they? Are they guarding when they move? And all of those things relate to what you were speaking about before, that we have this whole chain of events moving through the body. It's not just the pain's there and they point at it. How rare is that? And you'll notice you'll have patients that come in and you go, oh God, you could just cut me in half and redraw the other side and I'd be fine, because everything all my pain is on my right side. That was the side that I broke my ankle when I was playing touch football. That's the side that my knee has been a problem. I've had a hip replacement on that side. And you're just watching the unfolding of that chronic fascial dysfunction, that it is going to affect one area after another. I quite often make the analogy of a spider's web. So whatever is happening in one part of the body, the rest of the body is listening, and the rest of the body is responding by compensating. We have an expectation of how to do a certain movement. And if we can't do it the conventional way, subconsciously we are strategizing all the time so that we can get the same end result with minimum discomfort. And so we will compensate, we'll override areas that don't move as well as they should. But of course, as the old expression goes, we're robbing Peter to pay Paul. We're going to pay the price in another part of the body because this issue hasn't been resolved.
Oh, goodness. Alison, I'm going to stop you again.
You stop for as long as you like. Take a deep breath.
I am. My mind's not completely comprehending this, but I'm getting some glimpses. So, I thought I was being very clever when I'm assessing referred pain or the consequences of an injury by looking at biomechanical issues and by assessing, the synergistic and antagonistic muscles and their range of movements and strengths. And I have this very simplistic idea. You can almost draw it like a stick figure, this happening here, this causes that. And therefore this muscle shortened, that one. You're saying, yeah, well, sort of, but David, how does that explain how an injury on the right ankle affects pain all the way up the right side? I couldn't. And in the past, I hate to say this, Alison, how many times had I then gone into taking a mental health history, and wondering whether the pain itself had caused a mental health issue, and that being now the driver of chronic pain, and therefore taking my eyes off the possibility that there are true structural issues.
100%. And look, it's such an important point to raise because, let's face it, our emotions are just chemicals. They are going to have a physical manifestation, but it's a negative feedback loop. People who are in pain don't move well. That creates anxiety and depression, quite apart from all of the other things across the spectrum of mental health. But if someone is in pain, they're not socializing nearly as much. They can't go and play bowls, or they're off on the sidelines at touch footy. They're not really part of the team anymore. So that perpetuates that poor movement pattern, because one of the other real sort of nuggets that I have to sort of impart is that we have enormous autonomic neural system investment in fascia. So if you're stressed, if you're depressed, if you're anxious, if you're tired or cold, you don't move nearly as well as you otherwise would. So as a result, you can incur injury, which drives more depression, anxiety. And you watch people, this is what I'm saying, observe people that come into your clinic, watch how they're moving. Body language speaks volumes about what their fascial tissue is doing. Depressed people don't walk along singing zippity-doo-dah, just as people who are happy don't walk around literally staring at their belly button. So these are the sorts of flag situations that we need to be aware of, because there is so much. This is why I'm desperate to get the message out there that please take a peek through that fascial lens, and it will make you rethink every patient that walks into your door, walks into your clinic.
Oh, goodness gracious. Let me stop again. Okay. That there is a huge autonomic nerve investment in fascia. And clearly what happens in terms of mood up top affects fascial function. And yet, how many GPs know that slow movement is common in patients with depression? And we ascribe it to just an upper cranial issue, a mental health issue, and never even think that it could be a two-way street, that the movement itself, having been impacted by the brain, can actually work the other way around. Does it talk to the brain and keep the brain in a mode that perpetuates depression?
Absolutely.
Oh no.
Because you can, as we talked about before, if you start changing how tissue moves, and this comes onto a very important aspect of hyaluronic acid or hyaluronan, HA. And I'm sorry, but I literally get very excited when I talk about this stuff. And I do apologize to your audience if I sound like my mind is like a box of frogs. I'm jumping all over the place. But interestingly, with HA, if you don't move, we start to change the acidity in the extracellular matrix. And so we're changing the viscosity of those glycosaminoglycans. And so we start getting the stiffness. And you and I have all seen and spoken to patients that you say, you've just got to get up and move, even if it's just a little bit all the time. And this might be young people who spend their entire life in front of a computer, as well as older people that will say, have you got any idea how much pain I'm in when I get up and move? You don't understand. And you think, what I do understand is if you don't move, this is just going to get worse and worse. Now, take that to the other end of the spectrum. We've all seen people, me included, the day after a half Ironman or a half marathon or a big running event or something like that. We all move like we've just spent a week on a horse. Not very well. Again, the lactic acid that we have blamed all these years for causing that delayed onset muscle soreness is what is changing the viscosity of the HA and causing that densification within the tissue. Now, the big difference is that for an athlete, they will walk this off. They've produced so much HA that it will eventually be metabolized in normal movement and they'll be back to normal within 48 to 72 hours.
Oh, goodness.
Older person, if we can just convince them to move a little bit more, then it's helping to metabolize the HA that they have got. The longer we stay still, and this was proven in a brilliant research project a few years ago. They had a perfectly healthy, I think he was 26 years old, and they made him sit on his butt for 3 weeks. He had no injury, but what they did was they biopsied his muscle and fascial tissue at the beginning and then after 3 weeks. And even in a healthy individual, that muscular fascial tissue looked like an overgrown garden.
Good grief.
Because it needs stress. And by stress, I mean movement to allow the collagen to align to even give us anything like normal function.
The pain that we've always ascribed to the silly overdoing ourselves is not just lactic acid and torn muscles. It is actually due to densification of the fascial tissue.
That's a huge part of it. We do get some micro injury at the muscular level, but so much of it is the densification of that tissue.
And therefore, the treatment of which is continued movement, because that's what you want, because you need stress and movement to align the collagen, to allow for glide, and to reduce the densification.
Exactly right.
All right. How about the difference between isometric and isotonic exercises?
In what respect?
In the sense that one doesn't really move the muscles very much. It just takes a huge load for a long period of time. Is it helpful or unhelpful to the fascia?
Are we talking about something that would be an exercise program?
Yes.
Or are we talking about, so for that amount of time, it's not going to have a negative effect on the tissue. If, for example, let's take that a bit step further, somebody who is craned over a computer all day,
Okay.
somebody who is in an awkward position to work, say in a factory production line, a musician who is spending long periods of time in the same position, that's a completely different sort of isotonic kind of loading. Okay, so that is going on for hours and hours and hours and hours.
Gotcha.
And we're literally hanging off fascial structures by that stage. So you can appreciate that, well, that we could talk for days, you and I, David, but fascia is such interesting material in that we have something called stress relaxation. So imagine an elastic band, and I'm stretching. If I let that go, it'll recoil. If I put it around a thick wad of letters or something like that, and I leave it for a period of time, it breaks when I take it off. Now, we're not unlike that in that when we are in sustained postures for a long period of time, the fascia loses its capacity to recoil quite so quickly. It usually takes a good 24 hours before it comes back to normal.
Wow.
Now, if someone goes and drives to work, sits in front of a computer for 10 hours, drives home, they're exhausted, so they slump in front of TV for the rest of the evening and then go to bed.
Yes.
And then go and do that all again the next day, it isn't enough recovery time. So we are getting less and less valuable input from that tissue to even regulate how we move. And this is what can expose people to injury risk, because that proprioceptive capacity of the fascial tissue is being degraded.
Stunning. Absolutely stunning. You know, I just wonder in myself, in my patients with pain syndromes, chronic or otherwise, how little in their history I actually spend time looking at them hunching over a computer or sitting in a chair or not moving around. You know, one would think they're resting a painful spot, and maybe it's not all a bad thing. But you're really saying you really got to look the daily activity, how much are they affecting the quality of the HA, hyaluronic acid, and therefore the densification, therefore the function of the fascia, therefore perpetuation of all sorts of pain. We're not taking the right types of history.
A really thorough assessment is crucial. So even going back to, I will ask things like, have you ever broken a bone? Have you ever had surgery? Because scar tissue is massive in terms of how that can affect people's capacity to move. It's an enormously important thing. But have you got any scarring on your body? What surgeries have you had? So you start to build up, what do you do for a job? What do you do for fun? How do you spend your time away from work? And getting an idea of how much movement do these people actually do? And considering that more and more and more of us are doing sedentary work, this is going to become all the more crucial as time goes on.
Now, we've mentioned work that sits you in a position for hours and you get locked in. Alison, does understanding fascia help us as doctors understand repetitive strain injuries?
Without doubt, because you can appreciate that if we are moving in a very, very restricted range for a long period of time, that densification still has the opportunity to manifest itself. So you can appreciate that when somebody comes into me and they've got lateral epicondylitis, for example, I'm not looking to go and have them injected straight away at all, because I want to assess how well are those more distal structures that all attach up around that lateral epicondyle, or at least pass over that area, because again, we have another big, what we call a myofascial expansion, as we described in the gluteus maximus before. But as that tissue all sweeps up over that area, is it just sensitizing the periosteum, because remember, bone is covered in fascia as well. And so if we can create better quality movement in the more distal structures, is it unloading that tissue sufficiently to restore normal movement and get rid of the pain?
Now, you've mentioned the quality of hyaluronic acid several times in terms of change of acidity and what have you. Do dietary factors affect the quality of HA?
Look, the one that I can say without any hesitation at all is the importance of hydration. There's a little saying that says, happy fascia is wet fascia. Okay. And if we are dehydrated, that will definitely affect the quality of the HA, because we used to quote that it could attract over 1,000 times its own weight, each little finger-like projection on the glycosaminoglycans and the proteoglycans. But it's more like 20. But still in all, if we don't have enough fluid in the system, that's definitely going to be a problem. In terms of, and I've spoken to one of the foremost researchers in the world about this and how much we'd love to do a study about the effect of different nutrients on fascia. It'd be really tough to get that one through ethics, because you would have to be taking gut biopsies and trying to ensure that people were really sticking to a particular regime. Gotcha. Two things that have been mentioned, and I'm only mentioning these because you asked me, are vitamin C and collagen. There's a very interesting researcher in the United States, and he's done some really inspiring work about the combination of those two things. So powdered collagen and just vitamin C powder, taken at a preset time before perhaps a workout or someone even going for a walk, because the vitamin C has a very, very important role to play in the health of our collagen. And so, I would love to say, get on my high horse and sort of say, you shouldn't be eating sugar and you shouldn't be eating this and you shouldn't be, but they're the only things that we absolutely know are helpful.
Great. Because my next question is absolutely regarding collagen. How do I advise patients with these sorts of chronic pain issues, likely fascial, who are vegans or vegetarians and have very low intake of collagen?
Yeah, that is extremely hard, because as we both know, there's no plant source of collagen, and that's tough. But my recommendation for people in that situation would be doing a lot of sort of, say, static loading, things like that, because creating load on fascial tissue is what gets a response. And the best analogy that I can use is, if people want to build great big muscles, what do? Work against resistance. Our fascia is no different. In fact, just as a little interesting aside, we are not born with an iliotibial band down the outside of the thigh.
Really?
That develops as we start to crawl and then walk, because gravity creates a demand for us to have lateral stability. So that thickens over a period of time. Horse riders, and I dare say professional motorcyclists, have the same sort of structure down the inside of their thigh, because it is a response to demand. If we don't demand, we don't get. So it really just comes back to the old saying, use it or lose it.
Another thought that hit me about the importance of circulation of fluids in a microstructural level. How does this and the lymphatic drainage work together or against each other?
Just such a perfect question, because the lymph vessels, and we know the lymph vessels are soft-sided, they're not like an artery. So you can appreciate that that's one of our biggest challenges in an area that is very edematous, is to try and get that edema to actually start resolving, to give our lymphatic system a chance to drain that area. So the lymphatic system is embedded in the fascia itself. There's been some beautiful microscopic demonstrations of that. It's absolutely lovely. But If the lymphatics aren't working, then we're going to get stasis. If we're also not moving, that's all much, much more disastrous a situation. So that gentle movement, the old rest, ice, compression, and elevation, I talk people out of doing that now. So things have got to inflame to, I'm jumping a little bit here, but things have got to inflame to heal. And so things only become problematic when we get mixed up with chronic inflammation, when it won't resolve. As I explained to my patients, inflammation's got a beginning, a middle, and an end. And if we don't get to the end point, then we've got to intervene. But part of that is, resting it. We now know that all that's going to do is create an opportunity for the fascia to densify. Icing it, you're dropping the temperature, so you're delaying the capacity for the tissue to heal. Compression has never, ever really been proven to do the job that it's purported to do. And elevation, same thing. So people can wear, say, a bandage or something like that to give that area a little bit more support, to give them a bit more confidence. But compression as such, I don't really advocate it, because we've got to get gentle movement going, graded movement, working within the limits of pain to advocate normal functioning within that tissue as quickly as possible.
The hardest part for us as GPs is actually making a diagnosis and feeling very confident we've hit it right. From what I'm hearing, there aren't any imaging techniques or things that can prove to us that the fascia is dysfunctional.
I'm glad you asked that, because high resolution ultrasound is actually very effective, as is MRI, in identifying fascial tissue. In fact, real-time ultrasound, we can see the fascia gliding if we ask the patient to move. So, for example, if you've got them sitting on the edge of a bed and you're looking at what's going on in the quadriceps, for example, just getting them to gently bend and straighten their knee, you will see that fascial glide. So it can be very obvious. A very inspiring lady, Dr. Helen Langevin, she did a great study about low back pain, because let's face it, that's the big sticking point in clinical practice, because we just label everything non-specific. But I now work very much on a sort of a fascial basis, because that great big thoracolumbar fascia into which your latissimus dorsi inserts, into which glute max inserts in its uppermost sort of portions, that's where all of our deep and more superficial abdominal muscles all insert into that multi-layered tissue. It's a huge organizer. What Dr. Langevin did was she got people to passively flex. They had a setup in the lab, and the people with low back pain, not only did they have thicker thoracolumbar fascial layers, they didn't glide particularly effectively relative to each other. So even before you think about what's going on at a bony level, at a muscular level, at a nerve level, it can just be that thoracolumbar fascia has basically glued itself together, and you're not moving anywhere into flexion while that's not cooperating.
Wow. Okay, so when has GPs ever done a high-resolution ultrasound to identify fascial thickening and lack of glide? I mean, and the second question is, which sonographer is trained to look for these sorts of things?
And David, that I think is my job going forward, is getting the information more widely understood so that we know what we're looking for. A good manual therapist knows what they can palpate. They know what normal feels like. As I said before, I've been doing this for 40 years. So I know what it should feel like, and I know when it's not moving well. People can be stiffer than others. Guys who've never been able to touch their toes. So why is this any different? But if you compare left to right, if you compare a completely remote area, what is their capacity to glide like compared to what I can feel in that lower back? But if we can If we can get the message out there to sonographers and develop a reliable test, because we all know ultrasound is amazing, but it is only amazing according to the sonographer's skill level. So this is something that I think potentially is going to be a big area for development going forward, because we need to know this information to be able to really guide management so much better.
Yes, Alison, and how much more amazing it would be for me to share the results with the patient so they understand their problem without being labeled with anything, except to understand, yes, you actually have a significant problem.
Seeing is believing. And how important would that be in the workers' comp field?
Yes.
Because you can't, the imaging doesn't lie. The interpretation of it is important.
Yes.
Otherwise, we can draw some wrong conclusions.
Okay. Now, Alison, we have a two-part episode happening here.
We certainly do. I'm sorry, I do talk.
No. We needed all this as a incredibly important foundation to move on to the second episode, which I will highly recommend all listeners to seek this second episode out and listen to it. But I want to bring to an end this episode by really getting back to you now and really giving us key messages.
Key messages for GPs would be, as busy as you are, you don't need to spend a lot of extra time with the patient to observe how they move. And for the GPs out there that do palpate, I would urge you to feel the tissue in the area that the patient is saying they have pain, knowing that it isn't necessarily the causative factor. It may be the compensation, but feel a totally remote area and then come to this, just feel a few little places sort of on their back, for example. Is it really stuck? Can you feel that it doesn't glide? Does it feel lumpy, for want of a better word, underneath that tissue? Is it caught up? Is it stuck? So in terms of observing and palpating, then you start to get that correlation between what the patient is reporting and what you feel is going on. But I would urge doctors to get their hands on patients. It doesn't need to be a long examination, but people need to be heard, because a lot of people are getting overlooked and they get labelled difficult patients because medicos don't know what to do with them. The other thing that I would say, and I'm going to put in a little plug for physiotherapy or even osteopathy, get them to a physio or an osteopath that has been recommended to you or that you've worked with before, that you know does manual therapy. And early intervention can save a lot of wasted time and unnecessary pain and frustration on not only the patient's part, but also the GP's part.
And from what I'm hearing, especially with the incredible innovation, two-way innovation, certainly affect the mental health of the patient as well.
Without doubt.
Okay, I'm just going to make one more comment to my GP listeners. How many times have I observed younger GPs, even older GPs, palpate an area without really knowing what they're looking for, apart from trying to localize the pain? And what you've just described to us is not at all what we had been taught to feel. Is it stuck? Does it glide? Is it lumpy? How does it compare with the other side or remote area? Alison, never taught this.
Well, I'll be honest, neither was I. Even through my undergraduate anatomy training, even through my postgraduate physiotherapy training. Okay. And it's having an open mind, and it's totally changed my practice. And it's not a matter of, if you've got a hammer, everything looks like a nail. Yep. But when you consider the ubiquity of fascial tissue throughout the body, the fact that it is a proprioceptive system, that it is a force transmission organ, that literally it does so much. I'm looking forward to talking to you about scar tissue, because that is absolutely critical because we see so much unnecessary suffering on the patient's part because there isn't enough understanding of how fascia works.
Alison, thank you for opening my eyes and certainly allowing me to understand how little I know. And I just love having another way of looking at the human body, which constantly surprises me.
Well, we never run out of fascination, do we?
Yeah. Alison, I just want to thank you for this particular segment. And as I had said to the listeners, please look out for the second.
Thank you,
Alison.
David. Thank you very, very much.
Health Ed's hassle-free CPD just got even more hassle-free. You can claim CPD with one click after listening to each podcast. Plus, if you're an RACGP member, we'll lodge your CPD with the college on your behalf. With each podcast episode, you can now earn half an hour of EA and an optional half an hour of RP. When you finish listening, just click the orange Claim CPD button on the episode's webpage and claim your CPD hassle-free.